Good afternoon. I'm Dr. Sarah Smucker-Barnwell, and I'm a member of the Trust Board of Trustees. I'm so glad you're able to join us today for our 29th Telehealth Community Chat. As a trust policyholder, we hope you're familiar with our Telehealth Community Chats. I'm pleased once again to be joined by Dr. Margot Adams-Larson. So without further ado, let's get started. Margot, it's great to see you.
Super great to see you. This is always my favorite time to get together and chat about telepsychology and what's been happening. And we do this quarterly, right? And really try to focus on the practical how-to side of things from an ethical perspective. We get a lot of questions on the chats. We can't answer all of them, but we welcome you to put them in the chat or in the question box, and we look through those afterwards for the things we haven't answered. You can email us as well at telehealthcommunity@trustinsurance.com. If you have a question that is a burning desire, we'll bring it to the next chat. And we just love having some ideas to bring to you in terms of thinking about the things you're interested in hearing about on those evaluations. And so we gather some of our questions from there as well. Um, as a reminder, in your email, you do have a final copy of the bullet points and the slides, so you can look at the content that we cover each time. We do our very best to get the slides with acronyms in there. So if you want to flip back to that to figure out what that was, we're happy to provide those and hope we get most of them come up, and we'll put those down below as well. And as a reminder, we don't show the slides when we're chatting because we feel it's really conversational and a bit more rich in terms of the things that we're chatting about. So pull those out and follow along. And we are going to kick it off with some news items. And we actually have a lot of news items to set the stage today. One of the things to be celebrating in the news is that as of October 1st, 2025, Montana is the 43rd effective out of 43 enacted jurisdictions for SIPAC. It has come such a long way, and we are almost through all of the jurisdictions, and super exciting to welcome Montana to that. So, Sarah, I know you have a lot of more federal related news, so I will toss it over to you.
Thanks, Margot. It has been a rich news cycle period, I would say.
Mhm.
So last week, we saw something important happen on October 1st. This was the day that various federal COVID-19 waivers expired as they related to the public health emergency and specifically to Medicare recipients. Now, I want to acknowledge that we're going to be talking about Medicare and the expiration of these federal waivers in the context of a governmental shutdown. So, I think it's one of these things that we're going to go over our best understanding of the information at this time, and we'll continue to seek clarification as it's available. But my best understanding is that there are many broader implications for medical professionals who serve Medicare clients. For psychologists, however, the impact's a bit more limited, but I wanted to talk about its relevance for psychologists specifically. So many things stay the same for us, but specifically psychologists serving Medicare patients, delivering mental health services remotely, will continue to have a lot of things. Will continue to stay the same. We'll continue to have the ability to provide mental health services, including services for substance use disorder, the ability to provide telehealth into the home of a client that's permanently a benefit for Medicare recipients, the ability to provide telephone only care to Medicare patients, again, permanently receiving audio only care for psychologists, for mental health professionals. And I think we're going to continue to see limited restriction on geography at this time. So I think the bigger concern, as I understand it, centers on this question of the requirement for an in-person visit within 6 months of beginning care. And if you recall, before the pandemic, before the public health emergency, this was a thing. This was, if you saw a Medicare patient, again, this just relates to Medicare, it was the expectation that within 6 months you would see this client physically in person, and then once annually after that. But in the context of the pandemic and some of the, the challenges there, that was relaxed. So what we see now is that after October 1st, 2025, the answer, as I understand it, it's a little complicated, I'm going to do my best, is yes. For new clients, yes, it is required to see them within 6 months and then once then annually afterward. So for patients, however, that we began seeing during the public health emergency, so during the dates of the pandemic, and if you recall, there was 151, not 150, not 152, 151-day period following the public health emergency that was designated as also acceptable. So if we started a new client in that period of several years, then they do not need the within 6 month visit, but they would need a once annual visit thereafter. So, I mean, the all up answer is yes, there is some requirement to see people in person. Again, Medicare only. Now, I do want to mention there is an allowance to override this, and I'm going to make a quote. The quote from the website from Health and Human Services reads, if the patient practitioner agree that the benefits of an in-person non-telehealth service within 12 months of the mental health telehealth service are outweighed by the risks and burdens associated with an in-person service, and the basis for that decision is documented in the patient's medical record, then the in-person visit required will not apply for a particular 12-month period. So the idea is if you and the patient both collaboratively determined that the benefits of meeting in person at least once annually were outweighed by the risks and the costs and the burdens, then you could decide for that 12-month period that you're not going to meet in person. It would need to be documented in the medical record. Why are you doing it? What was the discussion? And then you have to renew it every 12 months. So you can't just do this once and then you're done. So these rules are a little bit different. I will mention for those in federally designated rural areas, for people in super federally designated rural areas, they kick the can down the road a little bit. And for these folks, the rule doesn't go into effect until the 1st of 2026. That being said, I think it's not bad for us all to be thinking about this now. And if you have a practice where you serve Medicare clients, and this is meaningful, and we're going to talk about this a little bit later today, we just want to be thinking about what is my relationship to physical space? Do I need to have physical space? Now, again, this is exclusive to Medicare clients, I do want to mention, but what we know is that it tends to be the case that private insurance looks up to Medicare. And so, what Medicare does often sets precedent for what private insurance, some of their policies they will adopt. So it's just something for us all to be keeping an eye on. In addition to this, we also saw from a federal perspective, the Telehealth Center for Medicare Services had a new proposed fee schedule for 2026. This was proposed in July of 2025. I think the last comment period just closed in September, and then we'll have the final schedule later in this year. But the proposed changes are worth reviewing, I think. Notably, we saw generally some integration of behavioral health codes with primary care codes, suggesting expansion of services covered, which is really favorable. A little more specifically, we saw that there's an increased reimbursement for originating site facilities fees. So if you're someone who sees your telehealth client in a clinic, in a nursing home, in some location that's secured, there's actually a little bit more reimbursed. I think it's regarded as an inflation adjustment, but that's favorable. So I don't think it's a tremendous amount. I think it's $31.85 in calendar year 2026, but it's a good thing. We see an expansion of digital health tools and remote monitoring that will be covered. So there are now codes for tools that monitor ADHD or behavioral health tracking. This isn't like telehealth as we traditionally conceive of it, but they fall within CMS's broader definition of digital health modernization. So it's a good thing. This is all to say we're going to see more technology-enabled healthcare covered, and that's favorable for those of us who work in telehealth. We see some new telehealth eligible services proposed for 2026, specifically group psychotherapy. So the CPT code 90849 hadn't always been covered in the past, and now it would be. And group behavioral counseling for obesity, G0473, I believe. That's something that hadn't always been covered in the past, and now would be. And then finally, the term direct supervision, according to this fee schedule. Now, this is more relevant to physicians, I want to note, but they are suggesting for physicians, they're now saying direct supervision could be met by a real-time interactive audio video, they are making the designation it can't be audio only. Again, this is mostly about physicians, expanded flexibilities and supervision, but it's interesting. I think it's interesting for psychologists because, again, as these federal regulation goes, often sets the tenor for other disciplines as well. So that's a lot. I think the biggest takeaways for me with all this news is that if you have a lot of Medicare clients in your practice, be thoughtful about whether or not you think that in-person requirement is going to apply and make plans for that. And then, long term, just be thinking about, what's your relationship to space going to look like? And if you are someone who offers group counseling, if you use digital therapeutics, if you have use that originating site facility fee, make sure that in 2026 you're getting the maximum reimbursement because this is all good news for us for the most part. It's a lot. It's a lot of news. I'm going to pause there.
It is a lot to digest, and I do appreciate hearing some good news.
Yeah,
I think just to wrap back a little bit to what you mentioned in terms of if folks are interested in having some clarification or more clarification at this point, it's an interesting time where we may not have as much feedback or availability to have somebody answering a phone or replying to messages that we leave because we're on short staff from the government side. So I appreciate that. But it does sound like moving into 2026 that there is some really positive progress in terms of what we're seeing for our coding and particularly with Medicare for their patients. So thank you for that overview, Sarah. Excuse me. Should we move into our first topic today?
sure. Let's do it.
All right. And that'll give you a chance to kind of peruse. We've got a lot of questions already. So,
There's some good ones. Yeah.
yeah, one of the questions we have had consistently is to have some discussion and information around the topic of assessment and psychological evaluation via telehealth. And I think on the most part, there are some really diligent folks who are thinking very conservatively from our standards of how can this even happen in a telepractice environment. And so I thought it would be helpful for us to dig back a little bit to where we all kind of started in learning about assessment and evaluation and kind of walking us a little through that process to then guide some considerations if this is something you're thinking about, or maybe you already are doing in terms of a remote practice approach. For the discussion today, I want to make a distinction between assessment and psychological evaluation. And to really kind of just distinguish that as we're talking today, psychological assessment, I'm really referring to things like IQ tests that have materials, that have protocols, that have books or materials that we typically might show the patient. They have standardized normative comparisons depending on ages maybe or populations. And they may also have proprietary information from the testing company, specifically those protocols or the questions that are asked in terms of that assessment. And I'm distinguishing that from the psychological evaluation, which is a bit more broad. Might be our clinical interview. It might be more question based. There might still be some standardized questions that we ask, but they may not be normatively derived in the same way that we think of in terms of the assessment measures. This might be based on an interview. It might be based on surveys that or historically paper pencil or now digitally generated questions that we might ask related to symptoms or symptom ratings. And so I'm distinguishing those apart because they have less materials and may seem more interactive in terms of the conversational style of evaluation versus assessments that may have more materials or objects to move around, or um, content that is derived in a normative manner that everybody receives the same question. So hopefully that makes sense that we start with that understanding. Um, and then I want to just raise some questions, raise some areas of things to think about. And, as many of us have trained in-person testing and in-person assessment and evaluation, some of these may transition easier to a remote approach where we're on the other side of a screen. But I do want to recall all of us back to some guidelines and some standards that still are there that we must think about when we're engaging in these areas of practice. The APA guidelines for the practice of telepsychology, approved in August 2024, and this time has a guideline, Guideline 8, that focuses on these areas in terms of our practice of assessment and evaluation. So I would point everybody to that resource as a great starting place when we're thinking about the application of assessment and evaluation in a telepractice manner. I want to point us all back to the standards for educational and psychological testing. That comes from the American Educational Research Association, APA, and the Council on Measurement in Education from 2013. And these are our resources that tell us and inform us about the standards for which assessments have been determined or based upon, and how and what our obligations are in terms of ensuring the validity, reliability, security of some of these tools once they are developed. And these are important standards to go back to. They do change over time, but our latest information is from 2013, and well worth reminding ourselves if we haven't looked at them recently, or reviewing on a fairly regular basis if this is something that you're looking to do or are doing in practice. All right, so we've got the resources out of the way. A couple things that I do want to bring to your attention in terms of the things to think about, considerations if you are contemplating assessments or evaluations from a remote approach. And the very first thing that I would focus you to think about is the purpose of the evaluation or the assessment. There are reasons for why we engage in the assessment. Evaluation, that's kind of one of those things that we probably should always be doing when we meet someone for the first time in terms of a clinical process. But when we're thinking about the psychological assessment components, thinking about why it is that that is something we're contemplating. Is it needed for an employment position or a fitness for duty? Is it for maybe an organizational purpose? Or is it for an academic decision in terms of um, understanding better the intellectual and academic functioning of an individual? Or maybe it's for a neuropsychological purpose. Maybe there was an injury or a trauma that occurred in terms of rehabilitation and needing to update some things. And finally, maybe it's for forensic purpose. Each of these purposes will have an important set of contemplations in terms of whether this is something you want to engage in, should engage in, is going to be accepted as valid or appropriate in terms of the recipient or the conclusions that are made from the assessment. And so really understanding the why behind what is the cause for the assessment is key. And I want to put a caveat on this. I've seen a number of areas where remote evaluation is used in what I would consider a blind manner, where folks are setting up to take a test to help determine whether or not they can go into a certain career field or um, a certain line of work. And making sure that part of the evaluation piece is meeting with somehow in some form with the assessee or the patient or the person that is the focus of the evaluation. We have ethical guidelines that speak into why or things that we want to look at in terms of making sure we know who it is we are evaluating. And if we have insurance that we're filing or third party payers, we do want to make sure we're following those requirements in terms of identification and who's using those benefits. So I'm going to leave that there and I'm going to come back to other considerations in terms of why or who you might be evaluating. The population or the specific patient involved. Is the remote administration being considered because of access to care? Sarah mentioned this in terms of, some people are so rural, there isn't availability to do assessments without a significant burden. Or is the patient themselves actually able to participate in the assessment if it's done in a remote manner versus if you're there in person? You want to consider the practical, technical, environmental factors of how you might actually go about the administration, particularly if there's materials, tools, computers that might be involved in that administrative process. And in particular, how you might navigate that assessment session, particularly if we're thinking about kids. There's behavioral management that often comes up when we're engaged in an assessment process. Who might do that if you are not in the room with them? Um, how might that happen? Would you instruct a person who is in the room with them? Yeah, if it's somebody who's in a long-term care facility, how might they even access the remote connection to participate? And that brings me to thinking about the testing site issues. So, on the patient side, what is that environment like? Is it noisy and have trucks dumping things like out my window here? Is it private? Is there another patient in their long-term care facility room sharing with them who might overhear not only your administrative prompts, but their responses? The security of the tests is beholden to us to navigate and manage. That's part of what we endorse when we are allowed to purchase the tools. And thinking through how you are going to secure that on the other end is important. I think the biggest thing for me as a long-term hardcore behavior theorist, the loss of observational data, which you see a screen here, which may not contain all of the data. It would be very difficult to do a gait analysis, for example, on a neurological screening if the patient is, only seen in this part of the screen. Certainly, there are ways around this, but you'll want to think about those ahead of time and plan it out, consent it out, document it. And that brings me to identifying what you're choosing to use in your evaluation and the limitations that may be there from validity, reliability. Are the norms standardized based on a remote administration or based in an in-person administration? These are all things you're going to want to know ahead of time as you're constructing that evaluation and assessment. You'll want to resolve any test security factors ahead of time, including making sure if there is somebody assisting the patient in the room with them, who that is, what they're doing, what they're exposed to in terms of the testing protocols, and having a good understanding of who might be behind the camera in addition to who you can see in front of the camera, similar as we would for a therapy session. Finally, you want to document all of these aspects. There's not enough emphasis we can place on documentation, not just for justifying why you're doing this, but also to help those who are uh, the recipient of the evaluation to understand the process that you engaged in to accomplish the evaluation. And so, those administrative procedures, if you're administering things remotely, you need to put that in the report. How you mitigated any of the issues that I just talked about should also be in there. And any third party observers or proctors, that should be part as well of that reporting. Finally, once you may have engaged in all of this and conducted the evaluation, any implications or limitations on the findings are going to be very important to look at because there's going to be some heightened scrutiny related to this change in process. And so, if you've got all these other aspects well documented, this should be something that you're also contemplating in another part of that reporting. So, to summarize, providing evaluations and administering assessments via telehealth certainly requires a lot of ethical and clinical considerations, documenting your justifications along with your procedures and processes, and any considerations on the implication for interpretation or care that might be recommended or recommendations from your report. Sarah, there's a lot there.
There's a lot there. And it's, I think it's one of those circumstances where it's what's in your individual practice. So I appreciate, Margot, you called out a lot of those resources like the telepsych guidelines for testing. Each of us is going to employ these tools differently in our practice. And of course, we're all working within our own organizational infrastructures or even as an independent practitioner, whether you serve a forensic environment, versus just your piqued curiosity as a clinician, making sure that you have a remote sort of assessment practice that is well aligned with what your objectives are and what your demands are. And this is a great call out, which will segue nicely into our next section for the advocate service. If you have a question about risk managing, something like this in your practice, this is a great opportunity. The Trust has our advocate service where risk managers who are quite facile in constructs of psychological service can help comment. This is kind of a nice transition to some of our live questions because I see an emerging theme that I want to be sure we respond to quickly and thoughtfully.
Awesome.
Does that feel okay? Okay.
Yes, absolutely.
Okay. So many excellent points here. Getting into the comment that was just made about the in-person visit within 6 months of an initial Medicare behavioral and mental health teleservice. So I really appreciate there are many people in the comments saying, hey, wait a second, within 6 months of the initial. Now, I think what's being called out is that right now, excuse me, I need to be very crisp with my speech, and I appreciate people pointing this opportunity. There's disagreement and interpretation in the middle of a governmental shutdown. Now, people knew this was coming. This disagreement preceded some of this. Whether or not that is perceived as within 6 months of that initial visit, which you can find folks who will opine that way, or within 6 months prior to the initial visit, which is the exact language. And so I think if we were trying to take the most risk managed perspective, I see a lot of folks in the chat saying, well, wait a second, if I wanted to do the most risk managed thing, and I think this is appropriate, wouldn't I want my first visit with a client to be in person? And I think that is a very sound best practice. If you want to be sure and you don't want to have questions, like, how are we interpreting this word? I don't want to hire an attorney for it. I think a very reasonable risk managed best practice is to say, okay, well, the first visit is then in person. Now, it's possible that you're saying, well, that is absolutely infeasible, and that cannot be done in my practice. That, I think, is a circumstance in which, we are able to document and talk about the risks and the benefits of having that in-person visit for a given 12-month period. In all of these instances, I think we want to understand our specific practice, our specific needs. It's a good opportunity to call the risk manager, call the advocate service for your specific demands. For the clientele that you see. And of course, a lot of us might work. Some of us are independent practitioners. I know I am. Some of us, I used to work for the VA hospital system, which had a very specific set of rules governing who we see, when, and how. So I think a lot of us may be working within other organizational infrastructure that we need to, of course, be cognizant and respectful of. But I think it is not an unreasonable best practice to say, like, it says 6 months within prior, it's confusing. And I think it would be a very risk managed approach to just say that first visit is in person. Are there people interpreting it otherwise? Yes. Can you find three experts and find three opinions? Yes. But I appreciate many people saying, wait, but a prevailing like best practice might be that first visit in person. So thank you for that clarification, everyone. And I appreciate the opportunity to make it crisper.
And I love your idea of get it out of the way. Make your
Right.
first visit that way. You can do your documentation. There's a lot of benefit to that, but certainly
Yeah.
there's some of those same challenges that may come up in terms of access to care and some of those other considerations that
Yeah.
you talked about. So,
There was also an ask for some resources. I know the resources I've been looking to most during this period of time have come from the telehealth.hhs.gov, HHS being Health and Human Services. Telehealth.hhs.gov has a lot of those policy updates. Go to the source. And then additionally, American Psychological Association has done a nice job, I think, posting and keeping us abreast of some of these policy changes and impacts for psychologists. So those are the two resources I'm using most. I hope they're helpful to others. All right, what are some other good live questions here? Did you see one that caught your fancy, Margot?
I did. I saw that somebody asked about the resources for the telehealth guidelines, and I am guessing you've already put them into the chat, although I haven't seen the chat. But certainly we have those cited also in our materials. So you
In our
can,
materials in that PDF. Yeah,
yes.
our favorites.
Exactly. It was a big theme in the ones that I'm seeing here. One of the questions has to do with updates on legislation for SIPAC, and I don't have an update for this for New York, but you can go to ASPPB, which is the national licensing organization for all of the licensing boards, and they have a link for SIPAC, and there is a map that will come up that can show you what states are new in terms of enacting legislation and then when they might go into effect. As of early, or actually late September, as far as I was aware, there's no other states that are enacted. And so at this point, I'm not aware that New York has any legislation.
I'm not aware of it either. And I think, there are reasons people would elect not to do it. There's some states that have proposed legislation and it hasn't gone anywhere, so we'll wait and see. I think there's a lot of question about who owns the revenue of such endeavors and questions about protecting the work of the psychologist within a given jurisdiction and thinking about how best to serve the clients in that jurisdiction. I'm not really opining on what I think is like the right way or the wrong way. I'm a known SciPac enthusiast, but I certainly appreciate there's kind of two sides to the story. And, I appreciate, I think we're starting to really live in an era where licensure mobility is much more meaningful for psychologists and what that means for ability to maintain long-term relationships with clients, to get the right specialty to the right client. It's exciting. It's an exciting time to practice. And I think it requires an extra layer of diligence, certainly. But, we'll see. I think, some of those big holdouts are going to remain, and we'll see if they ever come all together. All right. Well, Margot, shall we move on to some of our next subjects here?
Yes, we had some follow-up questions. Every once in a while, we get a question where we kind of need to dig in a little bit more. So I know you were digging into an international telehealth question.
Yes,
So
I
I'll
get this
pass that one
question.
to you.
I get this question a lot actually about international telehealth. Can I see my clients internationally? And I've heard it said that in some ways it's easier to see an international client than it is to see an interstate client. I think those quotes come more from when SciPac wasn't quite so widely adopted. And I do want to refer back. We have a webinar I actually did with through a joint effort with the Trust and the National Register. It's a 3-hour deep dive into interjurisdictional practice. This is a great passion of yours. We have 3 hours of their CE. Please check it out. But I wanted to give the broadest strokes. I want to remind folks that SciPac only facilitates interstate practice within the United States. So it's this great mechanism we have for participating jurisdiction states, but it's only within the US. Many countries do have governing mechanisms for interjurisdictional practice. So, you may go to another country and be able to find a way to do interjurisdictional telehealth there. I have a client who recently moved to England, and I'm really trying to figure this out right now. So practice what you preach. It's been a good experience for me to go figure it out. The first and foremost thing we want to determine is, does that country regard psychology as an entity that is licensed and has a governing board? So I think one of the trickier bits is you may have a client who wants to visit or reside in a country that doesn't treat psychology as a licensed profession. Really tough to figure out interjurisdictional practice when there's not another licensing board to talk to. I think that I do want to draw a distinction here between responding to an emergency versus, where I know my client is going to meaningfully move. I tend to feel like I know I've had professional circumstances in which a client has been in another country, in another state, there's something emergent happening. I'm not going to yell prank caller and hang up the phone. I am going to determine where they are, what local resources are there, and how I'm going to respond in emergent circumstances, probably why they're calling me in the first place. But I am going to try to do what I think is best in my clinical judgment for the patient. I have an ethical principle of not abandoning my client, that guides my practice. I think that's quite different from my client who's moving to Paris, and that sounds pretty good to me. But in that instance, there will be meaningful ongoing interjurisdictional practice, and there may or may not be a mechanism for me to do that appropriately. At the end of the day, I have to practice where licensed, and I have to make sure that I am following the rules of my license. I did have a colleague once say to me, like, well, am I going to be extradited to another country? And I said, no, I don't think you're going to be extradited for interjurisdictional practice. But if there was a complaint against you, that either went to malpractice, for some sort of damages, or went to your licensure board for investigation, starting off foundationally as practicing where you're not licensed is not a good look, for your liability, nor for your licensure. And so I think there is, tremendous risk to doing it. And generally, again, this is a circumstance where I advise folks to call the risk managers and understand the specifics of your circumstance. But if we know that in a long-term way, this client is going to be, moving to an international location, that we want to discover the governing board for psychology in that given country, that it exists. And typically, there will be some mechanism to contact many, particularly European countries. You'll see there is a mechanism for registration. Now, most of those have not been adapted to telehealth only. They're thinking of visiting physicians. They're thinking of a mental health therapist, seeking training or doing additional study. So they have mechanisms in place. They're often not telehealth only. That's a little bit trickier. So my recommendation is to find that board and communicate with them directly and, apply for the mechanism that's available to you. Again, it's often a little bit more geared towards physical in-person practice, but usually it is the mechanism that you need.
Well, and it's a place to start. And
Yeah.
as a segue, we had another follow-up question from last time's chat, and that's confirming that under SIPAC, when services are being provided, the provider must be physically located in the state in which they are licensed. And yes, under SIPAC, you must be licensed and physically located within the jurisdiction you're licensed in, and that you're indicating as your home state at that moment. And so those are very clear guidelines that they have indicated is the process for utilizing that SIPAC process for providing telehealth. Sarah, I'm looking at the time. I'm wondering if you
Yeah.
want to jump over to our other meaty topic related to artificial
AI. Yeah,
intelligence.
let's talk some AI. So I know this is a great example of something that's in the news. It's being talked about at a lot of conferences that I attend. It's just kind of like a hot discussion. And it's one of those areas where I think you and I, Margot, are even like, I don't think we disagree on it per se, but like I think we do have different perspectives. And I think we thought it might be fun to kind of like, I don't know, like share. I hope it's interesting to others for us to share the conversation that we're having privately in the context of the chats. And this is talking about some of the pros and cons. Cons might not be the right word, but the benefits and risks would perhaps be more accurately stated regarding the adoption of AI into our practices. And I think again, the Trust recently has put out a series of webinars with depth experts who talk about artificial intelligence in clinical decision making, in practice. And I really encourage folks to check that out for a deeper dive on the subject. I think we're speaking a little bit more casually because right now there are just a deluge of consumer oriented psychology products available to kind of everyday practitioners like myself. They're relatively new and not incredibly well researched because this is a new area. There's not a tremendous evidence base for this yet. I mean, but I don't know, I feel like that's telehealth, that's nothing new. A lot of times we are on the bleeding edge of practice, I think, when we think about technology enabled behavioral health. So today we talked about all these tools, that we could click on, including like clinical decision support, things like that. Let's just start with the most basic one. We want to talk about audio note takers and LLMs, in the excuse me, and the mechanisms, the AI mechanisms that support them. A lot of electronic health records now have an add-on product, or you can buy a standalone product that will listen in on your session and create notation for you. And you often hear them called note taking or note taking software or something like that. Typically, they offer very high fidelity notation because it's based on a transcript of your session. And as AI tends to do, it organizes it very neatly. Many clinicians who use this report that it is a pretty efficient way to capture patient information. It reduces their note writing time. I think one of the benefits, and I want to be totally transparent, I've not yet implemented it. I've been tinkering for months, as you know. It does a very nice job of allowing me to be present. I actually use AI note taking in other facets of my not PHI, not protected health information professional life. And the thing it does incredibly well is it lets me be present in the conversation. Because I think any psychologist knows part of the job is kind of splitting your brain between present, listening, catching themes, and also noting it down. Our memories are imperfect. We'll need to write good clinical notes later, and making sure that we're finding that balance. I think that these AI note takers are offering this unique way to capture high fidelity information while being very present. Now, of course, we're always checking how that data is handled, where to store it. I'll let you talk about that in the risks area. And I do want to say, in all the literature I'm reading, the tests I'm running, we must check our notes because no matter how high fidelity it is, we know AI makes errors. They do not capture the essence of a given communication. It is not unlike a first draft that people may revise. Some clinicians say, I find the revision more tedious, than frankly starting from scratch. Others say, no, it's so darn good that I think with the little tweaks, it really captures the information that I most wanted to capture. I'll share in my practice, I really do try to adhere to minimum record keeping standards for the jurisdiction that I'm practicing into, which my notes tend to be a bit more austere. And so for that reason, I'm a little more hopeful about the goodness of fit with my practice. I do think there's a longer term question of where is this information going if we start using it, even if it is handled appropriately within the confines of HIPAA. Is this training a helpful clinical decision tool for me in the future? Is this becoming a robot that will take my job? What is this? What am I participating in ethically? I'm not so worried about job loss as much as I am about, what are the ethics of what I'm doing and how I'm engaging in this? So I think this is something I'm coming down more on the pro side. I see a lot of the benefits of it. As I mentioned, I have not actually implemented my practice yet. That's because I'm just, I don't know, risk averse, and I'm going to read it 8 more times and practice, with a friend 12 more times. But I do think it's a tool I'm going to be using pretty shortly. All right, Margaret, I'm going to hand it over to you to discuss the areas of
Uh,
risk.
well, I want to come back to just one of the fundamental therapy faculty that I had way back when, who I was worried about. I can't take enough notes to keep track of the whole session. And his sage advice then was the themes will emerge and you will remember those. And be present in the session and don't worry about the notes. And sure, times change. But the thing I get concerned about is too much data, not enough focused, thematic, clinical content and decision making. And that's our brains, not training an AI model to make those for us. And I think if you transcribe everything, great. You can't not you making sure that you've actually read it so that it is accurate. And I will say I have a big negative perspective on the accuracy of AI at the moment. And sure, some of them may be really great. You could have all the data in the world in there, but that isn't necessarily all the things that make up that content and that kind of session. And focusing more on the theme and your clinical interpretation, I think, is really the essence of good documentation. Going back to what I talked about earlier, you could have all of the assessment data in there, and AI can help you kind of put that into a really nice summary. But if you don't also note in your note that AI helped you with that, you're missing a large part of that documentation. And I see that more and more that even as a patient going to the doctor, they want you to sign off that, their listening device can be with them. And their notes are not great. They're not accurate, but they suffice for what insurance is going to pay for. And so I come back to the ethical context of I was trained to do this work. I'm ultimately responsible for all of this. Sure, it can help me summarize things for my business meeting or other things that maybe I need some, kind of consistent automated things done. But in the tools of working with patients, do I want a third party in that session with me? I think is a really important question.
It's a great question, and I think that's a fair way to think about it too, because in some ways, where I think this is heading, right, is towards like these bespoke large language model AI, machines we see it already. Medical students, have, if you have medical training today, as I understand it, there's a decisional support tool. It goes, you have an iPad and you say, well, the patient has a fever. Well, are they dehydrated? They're branching decisional questions. And that is being automated, and we're much more meaningfully interactive with that. And we're seeing the development of that for an analog for psychology. These are not HIPAA compliant, by the way. So I do worry that people are out there saying, my client has this, this, and this, symptom. What do we think? Well, that is not HIPAA compliant. I think it's a great question. I think, the place I come down and is like, I would consider it for clinical notes where I am my minimum record keeping standards. I would not consider it, interestingly, here's my hypocrisy perhaps, I wouldn't consider it for psychotherapy notes. For psychotherapy notes is where I write whatever to myself, or that your dog's name is pajamas, or whatever, information. Not that that is my hopefully most astute clinical acumen for the day, but that there is process, there's art to what we do, there's humanity for what we do. And I think there is this question of where is the line of what's just a helpful administrative tool that allows me to focus on the things that need my humanity for the job, and what distracts from that, what ethically takes us away from that. And the question I'm always asking is, what am I participating in? Actually, I mean, truthfully, I don't have huge concerns about some of the more administrative aspects, and handing that off to a robot feels fine to me.
Mhm.
But what am I participating in to create for tomorrow? And what am I handing over my data, free of charge, by the way, to create? Will I feel good about what I participated in? Will I feel good about how my client population is served in the future, knowing that I had a hand in it? And I think that's the place I often get stuck, is I don't know enough about where the train's heading, if I totally want to be on the train. That being said, I do think it's a handy tool. I use it all the time, and it's also happening. And this is the place I always come back to. It's like, well, whether I like it or don't, it is happening. And so it's one of those things that, like, I think it's advisable for all of us to think about where we stand on this, and how we do or don't want to participate, with these products, because it is the trend, in the field. And we're just going to continue to see a proliferation of these tools and an integration into the tools we already use.
I do come back though to say just because we can
That's right.
doesn't mean we
That's
should.
right.
And, it's not just our data, it's our patients' information to some degree. And it's also um, our cognitive functioning that I have a large concern about in terms of we become reliant on these aspects and what happens if that transcript just isn't available? What happens if something went wrong and there was a glitch and you're now, okay, how am I going to come back to that? I think there still is important function in our clinical process of writing a note here and there of, not relying on things that we don't entirely understand or completely control. And I agree with you in terms of we don't know exactly where it's headed when we're thinking about the tools that are third party generated in maybe those electronic health records. If they're tools within our own office settings, sometimes those can be locked down. But again, my understanding of what that means and the understanding of what the developer means might be very, very different. And we're really coming to a process where we've got a lot of combined data out in the world that these tools are utilizing to make significant decisions, particularly in the world of medicine. I see that coming for psychology. And it, to me, separates the humanity and the human connection in a way that I am not yet comfortable with. So I'm really falling on the con side of, it's for me, there's some really simple things that, yes, I will leverage AI to help with some basic types of administrative function. I am not open to the door for it being present in my clinical sessions yet.
Well, we've been having these discussions or similar ones for about 15 years, so more to come.
Yes, I love it.
There was one question I want to be sure to answer in our chat because one of the folks mentioned and then pointed back to it and said, oh, this is a pretty important one. So I want to call it out if that's okay.
Go for it.
It says, as far as you're aware, would any Medicare insured patient who began therapy via telehealth any point before 10/1/25 be considered previously established telehealth patients and not required to be seen in person anytime within the 12-month period following 10/1/25? And that's worth clarifying. So here, this is my best interpretation. Clients who began as new clients during the public health emergency and the 151 day that followed, they kind of had this trailing tail to it. They are not required to have within 6 months, but they are required for the once annual. That is my understanding, unless you and the client collaboratively determine that the benefits are outweighed by the risks and you document it as such every 12 months and you're able to provide that documentation. That's my best understanding. And again, I really do invite people, if you have a question about your specific practice, the risks and benefits of your specific clients, reach out to those risk managers. It's kind of the crown jewel of the trust program for risk management. And it can provide a very bespoke answer because, these are incredibly idiosyncratic and important questions that, for your practice, for your patients.
Mm-hmm.
All right. Should we do one more, Margot?
Yes. Do you see a good one?
Oh, I saw a bunch of good ones. Let's see. I saw questions about folks who have no longer have an in-person office, I believe. I was talking about when you don't have an in-person office, and I do want to mention this is something we've covered more extensively in past chats, so forgive me if I keep tapping back, but there are chats where we've really done a deep dive on this. I think it's a great question and on our minds, particularly as some of these waivers call into question if we serve Medicare clients, like, well, do I need a physical office? At what interval do I need a physical office? My general ethos on this, I'll share, and I'm a 100% telehealth provider. And I have access to a physical office. I like to do this for various reasons, inclusive of my client, telehealth assessment for appropriateness is an ongoing process. It's not a one and done thing. And again, I have an ethos of never wanting to abandon my client. I have an ethical commitment to that. So if something were to change with my client, even though I'm not reliably, regularly an in-person practitioner, and I felt that the best thing for that client were to be seen in person, I would want the option to do so. So I'm a 100% telehealth practitioner. I've worked out how to exchange documents, how to do payments, how to provide super bills, insurance reimbursement. All of that has had to be worked out outside of the physical office, how to make sure they are who they say they are, to collect the appropriate information. All of that needs to be managed remotely. There's one thing that I always like to make sure I have access to, and that is if and when they no longer want to be seen, or I determine it's no longer clinically appropriate. And in those instances, I do want the option. So increasingly, I think folks have a more flexible relationship with workspace. I encourage folks to identify if I really did need to see someone in person, what would I do, and not wait until that situation is in their practice, but to sort of have an emergency plan, just like we have for every patient, have one for ourselves. What if I did need to see them in person? What would I do?
Mhm. I think
Or
that's sage advice. And there are times where you may not be able to be in your usual space when you're providing care, that having an office backup may be a good thing to
it's a
keep in
great
mind as
point.
well.
Well, we're getting down to the last bit of it, Margot, here today. And just by way of summary, today we did some updated news, some weird and complex news that hopefully, as the federal government reopens, will continue to provide you updates and clarification related to telehealth. Talked about assessment and evaluation via telehealth done remotely, navigating some of those changes in policy, and thinking about the pros and cons of AI implementation, specifically notation in clinical practice.